In this study, we were looking at the outcomes of RVD versus VD in real-world patients that were treated. And what was interesting is that in the overall population, the progression-free survival was improved with the triplet RVD by 26 months. But what we also were able to do in this, because it's real-world studies, look at subgroups, such as patients over the age of 80, and they benefited equally with all of these subgroups that I'm about to mention all had more than a 20-month benefit. So patients that were over age 80, Charlson Comorbidity Index more than 2, and also ECOG performance status of 2 or higher. So often these three groups of patients are not included in studies, so you really don't know what are the data. How many 80-year-old plus are included in a clinical trial? Almost none. So it's good to see that this triplet therapy in real world also still contributed to improved clinical outcomes with triplet therapy. I would say, though, I think it's important to use dose attenuation with these regimens to make sure that patients are tolerating them well. But clearly, dose attenuated RVD can be very well tolerated and associated with excellent outcomes. I think in general, we're learning more and more that clinical trials are really important to get drugs approved, but we really do need to balance that with real-world evidence, recognizing all the disparities between the two. And I think this is not just unique to myeloma, but in all of oncology, the clinical trial selection criteria are sometimes so rigid. We really need to broaden them, and particularly for myeloma, where our patients are older, they're going to have other cancers, they're going to have renal dysfunction. If we're not allowing these patients, how do we generalize study data to the people we're actually treating in clinic?